session.
Great. Well, hello, everybody, and welcome to the 10th webinar of the global platform on coronavirus and older adults in low and middle income countries. And I guess inevitably after 9 webinars, we're starting to go back and revisit some of the themes that we focused on in the previous sessions. And today we're going to be looking at the issue of care homes. Next slide, please. And if you're interested, and if you weren't able to participate, we ran a webinar on the same topic, really, back at the start of May, where we had papers from Thailand, Brazil, and a number of other countries. And if you go on that link in your own time, you can download all the PowerPoints and also the YouTube recording of that. And more generally, I'm sure a lot of you are aware that there's an excellent similar kind of network of academics concerned about coronavirus that have a particular focus on long-term care, LTC COVID, not just in low and middle income countries, but also in high income countries. And they publish a lot of papers, they run a similar webinar series. And just on Monday, they had an excellent webinar, which included this paper from Brazil, looking at some of the issues which I'm sure we're going to be discussing today. Next slide, please. And this is actually from one of the reports, one of the many reports that LTC COVID have published over the last 3 or 4 months, which shows that in the case of France, care homes accounted for about 1/3 of all reported COVID deaths for people of all ages, and about half of overall estimated excess mortality. So you don't need me to tell you that if you're concerned about coronavirus, you have to be concerned about care homes. Next slide, please. And perhaps historically, at times, people in low and middle income countries have looked towards countries like, for example, Canada, as examples of pretty good practice in terms of ensuring quality of service provision for older people, including in long-term care facilities. And in many cases that is true, but clearly, as in the UK, as in many other high-income countries, the coronavirus pandemic has really brought out the weaknesses of those systems, and with this kind of highlight, with this kind of headline. And one can imagine if these sorts of problems have emerged and have been reported in countries like Canada, that the situation in low and middle income countries must be even more concerning and even more critical. Next slide, please. But we know very little about the situation of care homes and coronavirus in low and middle income countries, because historically and continuing into the present day, these have received almost no attention from public policymakers, from researchers, from academics. And so we have very, very limited data on how many kinds of care, the numbers of care homes in many low and middle income countries, the different kinds of providers. We have very, very little data on reported cases and deaths from coronavirus in care home facilities in low and middle income countries. And we'll be exploring some of the reasons for that, I think, as we go through the webinar. And very little information about what different government agencies and other organizations are doing, particularly in parts of the world like South Africa and Latin America, where there perhaps are opportunities to learn from the negative experiences of countries like the UK and Canada to stave off or mitigate some of the worst effects of coronavirus on older people living in care homes. So hopefully we will be able to at least start to address some of these massive knowledge gaps during today's webinar. Next slide, please. What I've done in previous webinars, in the previous 9 webinars, is I've provided a little bit of background for each of the countries that we're going to talk about in more detail, just to give people a broad idea of the status of the pandemic, because clearly it's playing out in different ways in different parts of the world. And again, that's what I've done here for Mexico, Argentina, South Africa, and Kenya. And we can see that in all these countries, it would seem, in terms of certainly reported cases and reported deaths, that the trend of the pandemic is upwards, although that rate of increase would appear to be considerably lower in Kenya than in Mexico, Argentina, and South Africa. In the last couple of days, including last night, when we posted a new paper on the Global Platform website, several people involved in the platform have started to look more carefully at the quality and the availability of data on coronavirus, specifically for older people in low and middle income countries, and have found that the data, including the ones that we're displaying in this slide, are often very incomplete and unreliable, and often reporting of coronavirus cases and deaths indirectly resulting from coronavirus for older people is extremely weak and problematic in low and middle income countries. And this, I think, is becoming a new focus for the Global Platform, and will be an issue we come back to in a webinar, I think, in 2 weeks' time. So this is data that we've used to set the scene in previous webinars, and I still think it has some value, but we're increasingly starting as a group to engage more critically with the numbers that are being reported by official agencies. Next slide, please. Okay, this is my housekeeping slide that I show in every webinar, and I will just quickly hand over the reins to Lucas, who will tell people about how they can join in the discussion and ask questions during the webinar. Over to you, Lucas.
Thanks, Peter. Welcome, everyone. As usual, there are three ways that as you can engage with us in the discussion. You can make comments and questions on the chat. The second alternative is to use the Q&A function. You can post questions there and then we'll answer them. And we are also live streaming in YouTube, so you can post comments or questions there. I'm going to be checking them too.
Great. Thank you, Lucas. So next slide, please. So now I'm going to introduce our guest chair and moderator, who is my good friend Leon Geffen from South Africa, who has made many contributions to the Global Platform since it was established in terms of blogs and webinar contributions. Leon is a family doctor based in Cape Town, and like many important people, he wears lots of different hats, and I've just listed some of his hats here. So he's executive director for the Sampson Institute for Aging Research in South Africa. He's an honorary lecturer in University of Cape Town. He's a fellow of Inter-RAI. He provides advice on a regular basis to different government departments, particularly the Western Cape Department of Health. He's also an expert advisor to the World Health Organization on long-term care and the health of older people. Next slide, please. I suspect we're going to have quite a lot of gloom and doom today as we talk about coronavirus and older people in low and middle income countries. So I thought I'd try and at least balance that with a more positive account, which is a blog that Leon himself produced a few weeks ago, talking about a care home in Cape Town in South Africa, which had been able to, at least at that point, hold off the coronavirus pandemic, which was really beginning to hit, as I understand it, other facilities in that city, and was able to do that by following what you would recognize as being, sorts of protocols which are required by organizations such as World Health Organization in terms of testing, isolation, etc. But as Leon said himself, this might have been feasible in Highlands House, but in lesser resourced old age homes in low income settings, the scope to be able to do this would be much more restricted. Next slide, please. And this is an image at the top of one of the bedrooms in Highlands House from their website. So all of the rooms are single rooms, except for a small number of rooms for married couples. And there, underneath it, we just have a couple of images, one from India and one from Latin America, which aren't necessarily representative of all care homes in those parts of the world, but it gives us a sense of the diversity of the sector and the challenges for managing the effects of the pandemic, especially in less well-resourced settings. So that's all I've got to say. I'm now going to hand over the reins to Leon, who is going to manage the rest of the webinar. Over to you, Leon.
Thank you very much, Peter. Great pleasure to be here. I don't want to spend much time talking. Just would like to hand over to the speakers, just to say from a housekeeping perspective, each speaker will have about 10 minutes, and that should allow some time for chat. And if you do have any questions that you want to post, please just post them onto the chat question, where you can either ask those questions or a Q&A, and we will try and respond. So hopefully it'll leave us a good 15 minutes after the discussion to chat. Almudena Oseja Arroyo is the Secretary of Social Inclusion in Mexico City. She has a PhD in sociology, and for the past 25 years has been working on social policy and community building in Mexico City. So Almudena, thank you very much, and welcome to the discussion. Please, with 8 minutes after 8 minutes, I'll give you a 2-minute warning. Thank you very much.
Thank you very much. Good morning. Well, good morning here in Mexico. Good afternoon everywhere else. Thank you very much for inviting me to join this conversation, which I think is very important in the context of this pandemic. I would like, are we going to see the presentations that we sent, or should I share my screen?
Lucas, can you please share?
I'm sharing the screen.
No, we're still seeing the speaker slide.
Oh, okay.
You're on slide 11.
I'm
you
sorry.
go slide 12.
It's. Do you see it now?
Thank you. Thank you.
That's it.
I apologize.
It's okay. So the first thing, just to give a little bit of context about the population, the elderly population in Mexico City, we have 750,000 people in Mexico City estimated that are above 68 years of age. We usually have this this measure, I mean, like 68 years and plus, because for the last 20 years, the city started a specific support program, cash transfer program for the elderly, and it was established at 68. So since then, the city, the government in Mexico City, has been following up regularly, specifically on this age range of the population. The population above 60 is 1.4 million. Then I think it is important to also mention that in Mexico City, we have approximately 185, but it might be even 200 care homes or nursing facilities. And in these facilities, we're talking about private facilities that might have a population of 4,500 people, and public facilities around 1,100 people. So in total, we're talking about 5,500 elderly people living in nursing facilities. I think that is important to mention because it is a contrast with other facilities and with other countries in Europe, for example, which the percentage of elderly population living in care facilities is significantly higher. The numbers I just given you account for less than 1% of the elderly population living in care facilities. This means that a lot of the, mostly the elderly population remains at home and is traditionally taken care by the family members. Having said that, the other important thing for the context that you might need to know is that, as I mentioned, since for more than 18 years now, Mexico City has an institute. It's a public agency devoted to the elderly, and it has a team. And I mentioned it because I think it's an important feature to have in mind. We have a team of 1,200 government workers, all of them women, or 99% of them women, that for 18 or 15 years, most of them have been working in territory. They are outreach workers. They work very closely with the elderly population. And this all started because, as I mentioned, the government in Mexico City introduced a cash transfer program that it was aimed at helping to secure at least some economic support for food for the elderly. So in order to reach, and today the program has, it's an universal program. It is not a targeted program. So it was covering the whole population of Mexico City, elderly population from 68 years and older. That means that this outreach team has been working with the elderly population for many, many years and has a very close relationship with this population. So it means it's not only a program that has a beneficiary database and just occasional contact with the population. It is a program that has intense interactions with the elderly population and follows up on their status and their needs permanently. It has allows us to follow up now during this pandemic. So the next slide, please. So there are three, for the purpose of this conversation, there are three main changes that we have introduced during the pandemic. The first one is the regular work that I have mentioned that has to do with this monitoring, the outreach program. We turned that into a virtual monitoring program in order to protect elderly people and to keep them at home. So the 1,200 women workers that belong to the Institute for the Elderly have been doing daily calls to all the people that are the beneficiaries of these programs. So that's the main change in a regular work. But there are two additional programs that we have introduced specifically for the pandemic. The first one, you're looking at it, and it's monitoring and caring for the elderly population without a social or family network. It is estimated by the census agency here in Mexico, there are approximately 10% of the elderly population in the country, and it's not that precise, but it's about 10%, live alone. But that doesn't mean that living alone is you don't have a social or family network. A lot of them do. However, because of we do have contact with this population, we approximately knew that in Mexico City, 27,000 people might be in a situation living alone. So what we did is we did a rounds of telephone calls to all of them to ask what was their current situation in terms of living arrangements. From
Almudena, 2 minutes.
Yes, from that universe, there are 5,700 people that do not have a social network or family network. So this team of people is helping them with regular calls, everyday calls, to see what they need. Whatever they need, we provide them. We can go to the next one. And then there is the second program, which is a support for private nursing homes. These private nursing homes need sometimes a lot of support to reinforce their ability to deal with the health contingency. As I mentioned, there are 4,327 current residents in these nursing homes and 184 nonprofit senior housing providers. What we do, we also call them every week, at least twice a week, to all of these housing providers, and we ask them for the status of the population in case they have suspicion of contagion or positive COVID. We immediately activate a health protocol with the Ministry of Health, and we do we take them to the hospitals in order to have them protected, because symptoms in the elderly population advance very fast. So we don't want to wait since they are in a confined situation. Just
half a minute.
Yes, I'm just closing. Just to give you the numbers that we have updated from this week, is in all these senior housing providers, we have had unfortunately some deaths. It amounts today to 24 people that unfortunately have died in these care facilities. So we have a very strict control of this protocol in these facilities in order to avoid further contagion. All of them have all the isolation measures in place, and the Ministry of Health and the Institute for the Elderly, that belongs to the Secretary of Inclusion and Well-being, is constantly doing this monitoring. Fortunately, it has not been a higher rate, and we are working on it just to maintain this kind of protocol, a very strict protocol, in order to keep people in the nursing facilities safe and not.
Thanks, Almudena.
Thank you.
Thank you, Almudena. To go to our next speaker, and we'll have time for chat afterwards. Thank you. So Elizabeth Mutunga is from Kenya, and she started a NGO after her own personal experience of having a family member with Alzheimer's disease. The NGO is the Alzheimer's and Dementia Organization of Kenya, and she's going to be presenting together with Roxanne Jacobs, who is senior researcher at the Alan Fisher School of Public Mental Health at the University of Cape Town, who's been working on the STRIDE project. So thank you very much, Elizabeth and Roxanne. So I think you're going to be dividing the time between the two of you, and I will give you a 5-minute warning, Elizabeth, to let you know when your time's up. Thank you.
All right, thank you. Good morning, good afternoon, good evening to everybody who's joined the call. Thank you very much for the opportunity to present about what's happening in Kenya. Next slide, please. Okay, in Kenya, we do not believe in taking our loved ones to care homes. So a lot of people take care of their loved ones at home, and this is done by unpaid family members. The nursing homes are there, but some of them are also very costly and also very far from where the older persons are staying. And so families would rather have to care for their loved ones at home instead of incurring other costs. Long-term care in Kenya, is provided by two ministries, the Ministry of Health and the Ministry of Labor and Social Protection. The latter ministry provides social protection via cash transfers, but they do not contribute to the public or private health and insurance for older persons. The older people from 65 years and above, who are about 1.2 million in Kenya, usually get the money, and it's from a research that was done by Kipra. There are about 833 homes, 129 households have benefited since 2019. Next slide, please. So in Kenya, we are still at the nascent stages of understanding what dementia is. So a lot of people still do not see the importance of having dementia as a priority. This is because there's a lot of stigma, so people will not seek help. That it's considered as normal aging, either caused by witchcraft or because you're being punished by the gods for something you may have done. So a lot of people do not speak about having their loved ones with dementia. So people living with dementia and their carers usually would keep quiet and not speak about what they're going through. So from a report that we did with the Stride Kenya team and the long-term care COVID-19, it was stated that during this period, a lot of people living with dementia are having issues complying with the government measures that have been set apart, like wearing of masks. They do not remember that they should wear masks when they go out, even they don't even know, and they're also not comfortable wearing them. And then also a lot of people, initially when COVID started in Kenya, if you were found out of the house after curfew time, you'd be taken to a quarantine center. So we had a few cases of people living with dementia who had wandered away, taken to a quarantine center. So they are trapped there, and also there's a risk of getting COVID-19. Also, because there's late detection, a lot of people, like I said, because of stigma, will not go and seek help. And so a lot of people end up, so we are helping the caregivers through virtual meetings online to be able to send the messages to their loved ones so that they can understand how to communicate with them and telling them about the infections and 19 is all about. Next slide, please. Next slide. Okay, thank you. So a lot of the informal carers and the families of people living with dementia are, of course, facing health problems, financial constraints. Most of them have lost their jobs. Of course, family conflict, because now you're staying with the person who's living with dementia more than you used to before, because you either went to work and now you're staying at home more often. And so there's also diminished self-care for the carers. Also on the restrictive measures by the government, there's of course more time at home with the loved ones. And so we've had cases of physical abuse, and people are trying to cope. Either they want to leave, the person living with dementia wants to leave and it's past curfew time. So they are a bit worried. So family members are worried. So they either try and restrain them, which also can be viewed and is physical abuse, but maybe it's because they don't know what to do with them. And at that point, they really need to leave. There's also more calls to seek help from people. People have started noticing their loved ones are showing dementia-like symptoms, and also a lot of them have wandered away during this period of COVID-19. When we had the first case of COVID-19 in Kenya, the support that we are doing as ad hoc is to ensure that we have fortnightly meetings so that we are able to support the carers so that they understand how to live with their loved ones, what can they do. But most of them have also not been able to join these calls because of connectivity issues in some areas. Next slide, please. So what we have been doing to support people living with dementia and the carers, we are working with the Ministry of Health, and we are supporting by giving slides in their presentations on how to, so that as they train medical personnel and the police, they understand how to deal with the issues of dementia. And also we are increasing public awareness in Kenya. We are using a lot of social media to create awareness on dementia for people with dementia and even the ones who do not have loved ones with dementia. We're using digital and print media. And then also, like I mentioned, fortnightly meetings for the caregivers. And then also we are connecting families with other health practitioners like the neurologists, palliative care doctors. A lot of people are not willing to take their loved ones to hospital because of the care of COVID-19. And then also human rights, we worked with them to put in a paper to Senate so that people who have found past curfew time who do not seem to understand what they're doing are not mistreated and beaten and fined for being outside. Next slide, please. So the Stride team Kenya, we have Professor Ndete and Christine Musiemi, who I really want to thank, who have been very supportive. Of course, we have Professor Maggie Schneider, who is our lead, and the whole of Stride team and ADI. And I want to thank you for giving me the opportunity. Thank you.
Thank you very much, Elizabeth. Roxanne, over to you.
Hi, good day, everybody. So I'll be talking about care homes and older persons with dementia in South Africa. Just go to the slides. And this is work done with Alice Ashwell and Margie Schneider, also part of the Stride project. So I'm just going to jump straight into it. Okay, next slide. The care homes in South Africa, the public sector specifically, we have free healthcare, which basically, you can press the next one. So the animations can pop up, there we go. The free healthcare in South Africa, the public sector is basically supporting 84% of the population. Care homes specifically is reserved for the frail and the destitute. We have about 1,150 public care homes across the country, but there's an urban bias to their locations. They're more centered to urban areas. Not all of them are registered with the Department of Social Development. About 415 of them are. And those who are subsidized, the Department of Social Development only covers about 51.9% of the cost, for which the NGO sector has to cover the rest of the costs. Residential care largely run by the NGO sector as well as faith-based organizations, of which only 8 are subsidized and managed directly by the Department of Social Development across the country. Currently, the capacity of these care homes can't meet the demand. They are underfunded, and underfunded facilities basically due to subsidy cuts give preference to persons who can't pay, which means as a result, the poorest of the poor and those who are destitute, even though they are eligible, they don't necessarily get space. There are no dementia-specific care at public long-term care facilities currently in South Africa. If we compare this to the private sector, the residents carry the full cost of their stay and their care. This can go up to about 30,000 Rand a month, depending on which care package they select, able to afford. This is roughly, give or take, £1,400 per month, which is too expensive and is basically inaccessible to most South Africans. What we know thus far is about 16% of the population currently can access private care. We have just over 1,000 residential care and retirement villages in the private sector, and there's also an urban bias here. And some of them offer comprehensive care packages via multi-purpose centers that offer housing, support services, caregiver training, community outreach programs, and frail care. Dementia care in South Africa. Currently, we do not have any nationally representative data on dementia, but small studies suggest that most persons living with dementia are cared for at home by the family. We have a small study in the Western Cape area in Cape Town. There's a memory clinic. They had a very small sample, about 300 and something participants, about 17% of them, of persons living with dementia, were reported living at home and being cared for at home. And this is usually by a family member who sometimes have to actually quit their job to take care of the family member at home. And this exacerbates poverty, social and economic hardships. The state currently relies heavily on the NGO sector to provide dementia services. And what the NGO sector provides is psychoeducation, training of carers, and support. And this is a sector that is seriously underfunded. Next slide, please. In When COVID-19 struck, older persons in South Africa has not been prioritized. The long-term care sector is not currently represented on any of the coordination or advisory groups or bodies. The guidance protocols for the sector were provided very late. For example, in the Western Cape, they received the guidance protocols only 2 months after lockdown has actually started. We currently have no statistics available on older persons to guide coordinated responses, and there's a delayed and inadequate provision of personal protective equipment by the state for long-term care facilities specifically. There's also delays in obtaining test results, and this can range anything between 10 days to 14 days, which means the tests are obsolete. And cost for private sector testing is prohibitive. Continuity of care for other ailments were compromised during the time out of fear or where there are positive cases at facilities. Facilities are closed down, making it harder for people to follow up. And also basically anxiety and fear has also played a role. There's still no accredited training or registration of carers at the moment, so this made it very difficult to source relief staff during this crisis. Next slide, please.
5 minutes, Roxanne.
Okay. There's been financial implications for care homes, increased expenses as well as reduced income. In terms of increased expenses, the decision was made to lock down mobility of staff. Certain core staff and essential staff were asked to stay within the facility. So that also pushed up costs, accommodating staff, the purchasing of PPE and infection control materials, which runs into thousands. There was one care home that was talking about spending 350,000 Rand on chemicals and protective wear, employing temporary staff to provide the care demands in isolation and quarantine. So in terms of reduced income, as part of the lockdown regulations, we're not able to fill any vacant rooms within the care homes. Economically insecure families are also not able to pay. There were instances where subsidies were not forthcoming. And the community support and donations have died up because local businesses were on hard lockdown and closed. Financial support, therefore, from the government has also been inadequate. Next slide, please. Almost done. The impact of COVID-19 on persons living with dementia. The wearing of masks itself was very frightening and confusing to people. There were talks of ripping off their own masks or ripping off masks of staff members. And there's also certain behavioral difficulties. There's been disruption in their daily activities, so the daily program couldn't continue, like outside outdoor activities, walk, etc. Also that confinement. So often people are not just under lockdown, but locked up. So they're away from family visitors. And kind of confinement is not very good for persons living with dementia. Also, they would slip out, which is symptomatic and characteristic of dementia. So it makes it very hard to enforce any social isolation or distancing practices.
1 minute.
Okay. Daycare and respite care facilities provided by these facilities are also impacted because they had to stop those services. And this obviously created a lot of burden on home-based carers with little support during that time. Next slide, please. Just run very quickly. There's been a strong emphasis on infection control, and it's overshadowing the narrative of far more likely recovery from COVID-19. The relaxing of lockdown regulations pose new challenges, so it's looking at peaking infection rates, increase in staff and residents infections, struggling to cope with staff shortages during this time and increased care demands. Also, the mental health and emotional well-being has been neglected for staff and both residents, increased burdens and being isolated from the family and anxiety and fear and panic. Last slide. Anyway, so in conclusion, basically, the crisis brings an opportunity to strengthen a fragmented long-term care system in South Africa, introduce that dementia care focus, and also to put measures in place to have a coordinated crisis response for future. So it's to challenge government to prioritize care for older persons with dementia. Also, the sector itself, the care sector, needs to mobilize and engage more strategically with government. And also, As it also brings the opportunity to bring balance between infection and emotional well-being. So aside from counseling service and debriefing that needs to be in place, it's about creating those safe spaces for visitors to re-enter as lockdown regulations are lifted. And also the opportunity to turn hygiene interventions into loving care interventions. For example, hand washing routines can become an exercise where the individual can touch again and feel held, and that human contact that is so needed. And then lastly, the formal recognition or professionalizing of the caregiver sector and establishment of the caregiver register.
Thank you very much, Roxanne.
Thank you.
Thank you. Lisandro Marino is from Buenos Aires in Argentina. He is a psychotherapist. He's been working in care of older persons for the past 20 years. He runs a care home in La Plata in Argentina, and he's head of the Association for People Who Run Care Homes in Argentina. So thanks, Lisandro, and I'll give you a 2-minute warning after 8 minutes. Thank you.
Hi, thank you. To begin with, I'd like to say, well, first of all, thank you to Peter, his team, my colleagues for different parts of the world, and the people, well, from Kenya, South Africa, and my lab tacos country, Mexico. Next, please. Next slide, please. This is my country, Argentina, in South America, province of Buenos Aires, the city of La Plata. It's on your right. It's a city with 700,000 inhabitants. Next slide, please. In this brief presentation, I'd like to take a few minutes to look at these points more closely. The collaborative work of Red Mayor and Cámara de Hogares, the role of Cámara de Hogares in responding to COVID, and the multidisciplinary action of the health effectors that we call community networking. Next slide, please. Okay, I'm a psychiatrist, psychotherapist. I'm gonna reintroduce myself. I've been working 15 years in the field of aging, geriatrics, gerontology. I started my surgery, visiting older people in their homes. Then they came to my office. I got the idea of a long-term residence models. I was, and still am, not satisfied with the offer I met. Then I understood that expressing my opinion was not enough, and I had to get involved. And so I did. I opened my own residence back in 2012. Nowadays, it's 50 old people under our care. Still, I felt that it's not enough, so we keep working. My involvement in Asian events, study groups, association in gerontology, geriatrics, led me to the Alzheimer's Association, Psychiatric Association, until I learned about some topics like friendly cities for older people with the Professora Silvia Gascon, you got in the photograph over there, Nelida Redondo, Peter, Red Mayor La Plata. So I was able to see beyond the individual. I was able to see the problem in its social dimension. We start working in human rights for all people, informed agreement, geolocalization, and denouncing the flaws in the services provided. At the same time, in Argentina, these were the figures last year, in 1920, 65% inflation, 15% unemployment rate, kids and older people below what we call the línea de pobreza, poverty threshold. In that particular context, care home directors of the city of La Plata and owners go together at the Cámara de Hogares de la provincia de Buenos Aires. We create that camera. Next slide, please. It's important here to highlight that today Cámara de Hogares represent 45 institutions with 2,500 beds in our residences and more than 1,300 staff workers. That's the universe I'm talking about. The collaborative social work of La Red Mayor and the technical professional advice of the Cámara de Hogares made it possible for all of us to tackle and design a local solution to the crisis to our best understanding. One of the most delicate issues we need to tackle in our residences was staff training, compromise to following guidelines, and awareness of responsibility of looking after these measures for themselves, their families, and the old people under their care. That was a challenge. From learning to wash our hands before start working, to change his clothes and wearing PPE. Some of the employees need to make more than one bus connection to get to their workplace. We worked and insisted on the use of cloth masks, gloves before the authorities officially announced the measures. Next slide, please. The multidisciplinary action on the community is what has really helped us in the pandemic. Under this circumstance, what I would really like to stress is the importance of the 24/7 community networking since March 14, 2020, the day we locked our residence. Just for your record, the provincial government announced the first official guide for long-term residents after 45 days of quarantine. Until now, we have not received any PPE, call it mask shield, face shield, plastic poncho, or anything from our local authorities. After 100 days, I have not received any economic funding or support. Yes, no comments. Anyway, during all this time, we have contacted designers to improve the shields. We share the cost of the supplies. We are working together with voluntary workers from non-government organizations and small companies to help workers keep their work and produce face covers, plastic aprons, and other PPE equipment for our staff. We have held meetings with national and provincial authorities, with the local council, official telephone line for COVID statistics, hospital directors, medical associations, directors of social services, local newspapers, radio stations, TV and networks. We opened the floor to discuss with the local authorities and spread the information and facts of our situation. In the Cámara, we might not share the same views, of course, but we are open to discuss every single issue. We respect agreements and we are open of new views and possibilities. We are on our own. We don't feel the support of our authorities. We resist the best way possible the dissemination and the spreading of the virus in our old people and staff. The consequences of these actions can lead to very interesting and rich conversation. Unfortunately, we don't have time on this opportunity. Next slide, please. According, like Peter said, our population, when we listen, many weeks ago, we listened to Professor Vázquez from Spain talking about 70,000 dead in residence in Spain. We're expecting the worst. Today, we agree on the hard lockdown policy of our authorities. Our health system can't afford or face the impact of this pandemic. The population in Argentina is 44.5 million inhabitants. 50,000 got infected, 1,120 died, 90 of which were old people in care homes, not in the city of La Plata. These are our records. 2 residents resulted COVID positive and recovered, and 2 members of staff got infected and are under treatment. The network,
2 minutes.
Okay, this network I told you found in 24 hours 11 workers to cover the quarantine of the people of the staff infected. Yes, in 24 hours, we found qualified people to keep working with the residents. Next slide, please. I'd like to finish by pointing out two positive aspects of this pandemic. On the one hand, our community networking initiating actions and interactions that will teach us with many lessons as well as models to implement, promote, revise, discard in the short, mid, and long term. On the other hand, thanks to this crisis, the Ministry of Health implemented for the first time a geolocalization system that provides information on residents in real time. This allows for quick and precise action for those in need. It goes without saying that this is one of the many long battles Red Major and Professor Lloyd Sherlock has been fighting for. It's unthinkable to work consensuously in an area that is unfamiliar, not to say unknown, to the authorities. All our efforts are focused on providing welfare to our residents. We are trying to minimize psychological and physical consequences of this lockdown. Next slide, please. Thank you very much.
Thank you very much, Lisandro. Peter Lloyd Sherlock, who probably needs very little introduction, but for those of you who don't know him, is the Professor of Social Policy at the University of East Anglia and International Development. It's got a wide-ranging, lot of interests, particularly in low and middle-income countries, to do with aging. And I think probably was one of the first 5 or 6 people globally to look and say, we get started in sort of, I think it was late January, early February, when Peter started making noise about needing to provide decent care to people living within care facilities in low and middle income countries, noting what COVID was starting to do to people living in care facilities, and particularly amongst older people. So Peter, thank you very much. You've really been at the forefront of this fight, so over to you.
Thank you, Leon. So this is a brief presentation which effectively summarizes a paper that the Global Platform published a couple of weeks ago with a number of co-authors, including Leon, actually. And it's really just trying to set out a simple plan to inform public policy for care homes in low and middle income countries. And we hope to update this and provide enhanced versions over time. And if you have any valuable or useful relevant contributions, please send them to us and we will incorporate them and we will acknowledge you as a co-author. It's not rocket science, it's not complicated, it's just trying to provide some general guiding principles. Next slide, please. And these guiding principles start with trying to get a realistic view of what residential long-term care provision is like in many low and middle income countries. And of course, we know that there are some providers which are comparable to Highlands House, the care home that I talked about at the very start of the webinar, with excellent facilities. But the large majority of the very rapidly growing numbers of residential long-term care facilities in low and middle income countries are very different. And I think for the purposes of our emergency strategy, one of the things we try and do is look at 3 broad categories of care homes. Care homes, nursing homes, different kinds of residential facilities, which are officially recognized and registered and certified. But we believe that in many low and middle income countries, and we have growing evidence for this, that there are many people providing residential long-term care services, often on a for-profit but quite informal basis, who are not registered with official agencies and might be described as clandestine or invisible to public scrutiny. And thirdly, there may be some collective living arrangements, perhaps workers' hostels, other kinds of arrangements, where over time the residents have aged, and they may not consider themselves as long-term care facilities, care homes or nursing homes, but as far as the COVID pandemic is concerned, they are a collective residential institution containing large numbers of older people. Next slide, please. I don't want to generalize, but I'm going to have to generalize about some aspects of long-term care provision in some low and middle income countries. And I'm also very mindful of a need to avoid making simple contrasts and comparisons between what is a very diverse sector in low and middle income countries and also a very diverse sector in high-income countries. Some of these general statements, I think, may apply to a greater or lesser degree in some care homes or in some wider national settings in the global north. But I think as a very broad generalization, they are more, these are more apparent. The degree of these issues is much greater based on the evidence that we've been able to collect in Latin America, South Africa, Thailand, India, China, and a number of other places. One interesting observation, and we heard about care homes in South Africa not providing services for people with dementia, is that many care homes, particularly in Latin America, contain older people who don't actually have any care dependency, which is interesting, and we could talk about that. Generally speaking, of course, many care homes have very limited resources, and it's quite usual, it's much more the rule than the exception, that rooms will be shared, possibly up to 6 or more people, very little trained staff, access to different resources. The evidence suggests, I mean, it's great to hear people talking about a rights-based approach to the well-being of older people in residential care. But broadly speaking, across the sector, those people working in the sector and even some of those people responsible for the sector, conceptions of human rights are very limited, and you see widespread use of restraints and doping, which could easily be averted with more enlightened forms of management. We talk about problems of regulation and quality assurance in countries like the UK, but in the most low and middle income countries, we're not talking about problems, we're talking about an almost complete absence of regulation or quality assurance, not just for those many unregistered care homes, but also for many care homes which are on the lists of official agencies. De facto regulation is almost missing, is very limited. And finally, and again, we do observe this in richer parts of the world, but I think it's a much more present issue in many low and middle income countries. Local level responsibility for residential care, jointly shared between local agencies of health and social welfare or social development, but almost no relationship between those two different departments, a complete institutional disconnect between them. Next slide, please. So this is why a business as usual approach, but it wasn't working very well anyway, but it is particularly problematic in the case of coronavirus. So this is a newspaper report about Buenos Aires in May. 5 people died, 90 more cases in a single care home. The first case in that care home was reported to the authorities by the director of that care home 6 weeks earlier. He received almost no support from public agencies and tried to isolate residents, but didn't have the resources to be able to do that within the care home, and now is under official investigation for breaching very rigorous and, I would argue, unrealistic standards and protocols for service quality, which theoretically exist in Argentina, but really just exist on paper rather more in reality. And of course, this is very concerning, this story, and what I'm sure it does is discourage less enlightened care home directors than Lisandro to report cases of coronavirus and cooperate with the authorities, because they will be held to blame for what is a much more complex problem. So next slide, please. In the light of that context, and in recognizing that we have to take a new approach really to these issues, we put together this simple framework that we call the CEAT framework. C stands for coordinate, The starting point for an emergency strategy has to be developing a much, much more effective working relationship between health and social agencies at the local level, a seamless relationship as far as possible. And for that to happen, that will need high-level political support. Don't make the mistakes we've made in the UK and in high-income countries where there hasn't been high-level political support for policies for long-term care and coronavirus. One of the first things that interagency task force needs to do is develop basic and realistic guidance and standard operating procedures, which are feasible for all of the care homes within their area of responsibility. Having done that, or perhaps in parallel, you need to go out and find those care homes. You can't do much about mitigating the effects of coronavirus in care homes if you don't even know they exist. So you need to go out and find and engage with not just registered care homes, but with clandestine care homes, with what I call de facto care homes. And that will require different kinds of strategies. It won't be just going through official registers. It may require working with local NGOs and other organizations to be able to identify these care homes. In some cases, and this is quite a controversial issue, I think there are grounds for offering some care homes a limited amnesty in exchange for their cooperation. So if you've got very, very unrealistic laws and regulations and protocols for how care homes should function, the numbers of people per room, the numbers of smoke alarms, etc., etc., it's very discouraging for care homes to engage with public authorities because they're concerned, quite understandably, about prosecution. At the moment, I think we have to focus on the greater good and the most urgent issue, which is to encourage care homes to come out of the shadows and to feel safe and open in terms of their cooperation with authorities. And therefore, offering some kind of limited amnesty or exemption is extremely important. In fact, we've been able to encourage some local governments already to do this, including to some degree the province of Buenos Aires, the government of the province of Buenos Aires. Once you've got your task group together, you've identified the care homes, and you've been able to hopefully bring as many of them as possible on board, you then need to do some kind of simple emergency survey of how vulnerable they are and how much they've been able to prepare for the coronavirus pandemic. And we've worked with Lisandra's group, as well as with people in different parts of Brazil, to develop simple online surveys, which have already been deployed to try and identify the main problems facing care homes, and within the overall community of care homes in a certain setting, identify those care homes which are most vulnerable and most at risk so that they can receive targeted support. And that targeted support can take a whole range of different forms. I'm not going to talk about that in detail now, but the ethos here, again, has to be to support care home managers, not to prosecute them. And only where care home management is really very poor, where you're seeing widespread serious concerns of abuse of older people's human rights, should that management be taken over by other authorities on an emergency basis. Next slide, please. We are seeing this, by the way, is a kind of schematic review of what we're talking about. So on the left, we refer to this interagency coordinated approach. You then have to think about different kinds of care homes in terms of whether they're registered or not. You then try and get a complete overview of provision in your own location. Then you assess, and then you provide targeted support. So in a nutshell, that is those are the bare bones of our CEAP framework. Next slide, please. Elements of this are already being implemented in different parts of the world. This is the city of Belo Horizonte in Brazil, where they did a short, simple survey trying to identify which officially registered care homes were at greatest risk. We're able to identify a small proportion of them which are at especially high risk, and they have since received targeted interventions of various sorts. And of course, what that means is that it is possible to focus limited resources on areas of greatest vulnerability. That's all I'm going to say. Last slide, please. This, we need to raise the profile of care homes and coronavirus in low and middle income countries. But not just raise the profile of the issue, but we need to develop realistic suggestions about what we can actually do about the problem. Leon and I both worked on the WHO guidance, which is wonderful if you're living in Geneva, but isn't quite so useful if you're living in more resource poor parts of the world. This is a newspaper report about a study that my colleague Carla Giacomin published a couple of days ago in Brazil, predicting that potentially 33,000 older people in Brazilian care homes could die as a consequence of the pandemic. And again, making what I think is a very important point, that there's no point simply blaming these care homes for the limitations of quality of the services they provide. The solution has to be some kind of partnership and a much greater sense of collective responsibility. So please, try and find a moment to look at the policy paper which I've been referring to, the CEAP framework paper. Send me your comments and your thoughts, whether you think it's any good or not, whether it is relevant to your own countries. And if you want to make further contributions to it, we will be trying to develop a new version in about a month's time, and we will acknowledge those. Thank you very much.
Thank you very much, Peter. I'd welcome any Q&As or chats if you would like to add any comments, ask any questions. Just a few points from what everyone has raised in today's discussion that I think we can take out. First of all, the point that Peter makes. This is not rocket science. Simple interventions can go a long way to mitigating the effects and the harm that COVID can do in facilities. Simple things like PPE, everyone should be wearing masks, hand sanitizing, education of staff, and practicing physical distancing. I personally don't like the term social distancing. I think we can be physically apart but socially cohesive. So in our facility, we've moved away from using the term social distancing. I think the lack of, is one of the issues that's been raised, the lack of PPE supplies in facilities. And one of the big issues that we're facing is the asymptomatic carriers. No matter what we do in terms of screening people are coming into facilities due to the lockdown. Asymptomatic carriers are a significant problem in facilities. And we know that from our original data, about 60% of people coming into the facility who were positive were completely asymptomatic. Right through the complete course of the 14 days of quarantine and isolation. It's apparent that there's a significant lack of data in the sector. And that means that it provides us with an opportunity. When I talk about us, I'm talking on a global basis, to become sort of the sector taking care of itself, because we can, by sharing information, sharing resources, not having to repeat what everyone else is doing, because everyone's providing pretty much the same sort of guidance. Everyone's trying to do very much the same sort of thing. But we need to start taking care of our own ourselves and sharing the data. Many countries aren't collecting data on mortality or total number of infections in care homes. They will maybe publish the total number of deaths or the total number of cases reported according to age bands, but not where those infections are occurring. I think one of the things that we need to consider is, can we leave the sector stronger post the first phase of this or the first wave of this COVID epidemic? Because COVID's not going away. It's going to be here for the rest of our lives. It's going to be the year into the future. We're not going to suddenly wake up in 6 months or a year or 2 years' time and say, well, COVID's gone away. We've had 5 million people in this world probably infected. We've got another 7.5 billion to go. Either who are going to get infected or become immune to it. So it is a significant problem. I think one of the most important things that we must remember is that care facilities are people's homes. This is where people are coming to spend the rest of their lives. Many people come into facilities and very few leave on their own 2 feet. Most of the people who do live in care facilities will leave and go and pass away in the facilities. But the care facilities provide an enormous opportunity for economic advancement, skills development, work for a significant group of the population. These in particular are women. So we need to say that by enhancing and strengthening the sector, we're providing a place for older people to spend the rest of their lives, and also a great economic opportunity. And we need to start reframing how we perceive the sector as, rather than a cost drainer, a cost incentive and a cost opportunity, or an economic opportunity for society. So that's my editorializing, and hopefully we can open up some of the chats and ask some of the questions that are here. Just one of the issues that, one of the points that Peter raised under the coordinate of the CETNet is that from our research institute, we've put together a policy document based around what we know has been the best guidance from many countries around the world, as well as practical experience garnered from working on the ground. Willing to share that, and it's actually been put out. It should be on the LTCOVID.org website, but if anyone sends us emails, we can actually just share that with you as well. Would like to say it's evidence-based, but at this point, I don't think there's anything that's evidence-based in the field of COVID, because it's too soon into the epidemic. We're only barely 6 months into the epidemic. We'll probably start getting good evidence in the next 6 to 12 months. So please open it up for discussion. We've got about another 10 to 15 minutes to go. Lucas, is that correct? Another 10 minutes before we get shuttled from our, we usually keep to quite strict time.
That's right.
Okay, so let's see what we've got in terms of the questions. Catherine asked, can we put the link to the paper on in the chat box? Peter, can you put the link up? It's on the LT COVID website, but Peter, maybe you can just put a straight link up to it on the website for people on the chat box.
Yeah, I'll do that.
Okay. A question from Wala. To what extent social media could tackle stigma in Kenya? How and what kind of media can reach more people from your experience? Elizabeth, would you like to address that?
Okay, so what we've been doing, we've been using Facebook a lot. We've been trying to create awareness, especially people understanding what dementia is and what it's not. And we've been having a lot of people asking questions, people saying, oh, but if you take coffee, it will help. So you can see the conversation is going on. And then also we've been using the national television that are there that people watch frequently to just bring the issues of people living with dementia and their carers, and what we require, where we need the government to come in and support, and what we are doing so that they can see where they can come in and plug in. So we've been trying to use even the print media to try and put out stories, individual stories of people who are going through, especially carers, giving their stories, because like I said earlier, detection is quite late. So we do not have people living with dementia coming out to give out their stories. So it's the carers who give their stories.
Thank you, Elizabeth. Right. One of the things I think is vitally important, this provides us an opportunity to educate. I think if we do work with the caregivers who are working on the ground, one of the big things that we faced is a fear and a threat of not coming to work because there's inadequate PPE supplies, etc. And I think one of the things that we've moved away from in terms of the fear is by educating, by walking. One of the things that I've certainly learned about is walking the floors has taught me to engage with caregivers, to recommend the physical distancing, to wash hands, to use extensive amounts of hand sanitizer, and to keep surfaces clean, and just to engage with the residents, to engage with caregivers. The more we do it, the more effective we will be at combating this infection. I don't see very many questions coming up on the chat box over here, so maybe to sort of give it anyway, and let's just have a quick whip around of all the other. Of Lissandra, would you like to make any further comments?
That point about education, yes, that's what we call 24/7. Every day you have to be on that details. That details are the one that gonna keep safety your residents, and the people that work inside. Yes, education, hygiene, and the cleanup of all the place, of course. Yes. We don't know what's gonna happen when we open the lockdown we have nowadays. Yes, it's gonna be I don't know what's going to happen, but we have to insist in education for the workers, the residents, and of course their families. Yeah.
Yeah, Lysandra, I think we're going to be going through multiple waves of COVID infections. It appears that way. It seems that that's what's happening in other parts of the world where we've been through a first wave and now hitting a second wave. Almudena, Peter's asked, can you give some experience of the CEAT framework that's been implemented in Mexico City? You're on mute.
It was silence. Sorry.
Yours.
Yeah, I think it will be very useful in terms of following up on these nursing home and applying it. I was just, as you were presenting it, and I was just looking at it, I was thinking there are several things on the framework that I think we do have some information, but not on others. So I'll be happy to, to talk with you in detail, and maybe we have the opportunity to move it forward here in Mexico City. We'll be gladly be, implementing it. I think it will be very useful.
Thank you. Almudena, any further comments you'd like to make with regards to the talks and what everyone's raised through chats, etc.?
Yeah. I would just like to say that as in many of your countries, thank you very much for all the presentations, very interesting. But I would like to say that many of your countries, many of these issues, we knew they were there, but the COVID situation had put them, in the front line. And I think it's been an opportunity to revise all the information, the data, and the protocols that we have in place, and not to let them, go anywhere anymore, and just strengthen, like Leon or Peter were saying, just to strengthen all the work that it's being done with the residences. And I think especially for us at least, it's a lesson for a very strict monitoring and support of these nursing facilities from now on, much more so that has been in the past.
Thank you. Thank you. Elizabeth, would you like to make any further comments?
For me, I think I've learned a lot, and I was putting down the notes as Peter was speaking, because for us, like I said, people do not believe in taking people to care homes, but I think this will change with time, because also a lot of people have to stop their lives, and maybe even their loved ones are not in that center, and so they are not able to even be able to care for their loved ones, so they may need to put them in a home. So it's a very valid conversation, and we just need to ensure that even as we are having, like you said, even if we need to go and identify, and even the ones which are not registered, because there are many in Kenya, but there's still a lot of work that needs to be done. But this was a very insightful conversation. Thank you.
Thank you, Elizabeth. Roxanne, any comments from you?
Hi, thank you, Leon. I think just to reiterate the point on the need for data, especially within the sector, we need surveillance of the long-term care sector, especially with regards to people living with dementia, because currently there's so much that we don't know. And with all of what we don't know, we need to really institutionalize this kind of surveillance to have really coordinated responses to this crisis. And I think now is the time, especially in the time of crisis with COVID-19, now is the time to mobilize and engage, and for the long-term care sector to start networking and having a voice and speak as one voice to the relevant stakeholders, which is primarily government, and engage them so that we can put older persons and their needs, and especially people living with dementia, on the public health agenda. So yeah, in a nutshell.
Thanks, Roxanne. Margie Schneider from Cape Town, who's sort of probably mentored many, many people through lots of issues around dementia and people living with mental health issues. Margie, would you like to make any comments?
just to add that some of the stories that we hear in South Africa is about long-term care facilities having to develop very proactive and strategies to deal with the crisis, especially as there was very little support forthcoming from the government agencies. And that a lot of them came up with really positive stories. And I think we need to also start highlighting those kind of ways of managing that proved to be really quite positive. So I think to also add that to the narrative.
Thank you. Thanks, Morgie. I just want to make comment that Carlos Jacoman, who's Carlos been, I think, mentioned in a couple of papers that have been mentioned over here, and been very active obviously in Brazil. And I think Brazil, we well know, has been very severely hit by COVID. And I don't make any politically incorrect statements over here, but it seems like there's certain political agendas or countries that have dealt with the crisis worse than others, and I think it's very, very indicative of how certain governments have engaged with issues around COVID. Carla, I mean, I think Brazil, we watch and sort of shudder to look at what's happened. And I think it must be incredibly difficult and challenging for you to work where you are. Peter, leave the last word to you, please.
Thanks, Leon. And yeah, I agree. And hopefully, Carla, who spoke in our previous webinar on interventions in Latin America, I'm hoping that there'll be an opportunity to draw on some of her very important experience about care homes in Brazil, which is something that I'm engaging with her quite a lot about. I think clearly there are important issues there. Couple of quick points. One of the things that I tried to do today, and I think it's actually it's very important, that when we're engaging with these sorts of issues, we need to bring different kinds of people around the table, not just from different parts of the world. So today we've had contributions from policymakers, from people who are actually providing long-term care or engaging with long-term care providers as physicians, and from academics of different sorts, including social scientists. And I think we really have to make sure that we are working together in that way, because clearly everybody, you know, Lisandro's perspectives I found really interesting in terms of really quite a responsible and proactive response from care home providers, at least some care home providers in his city. Obviously the insights of people like Almudena in Mexico are absolutely critical, because we know that government agencies have to play a leading role in dealing with this pandemic, and then of course academics. So hopefully that's a model that we can apply in terms of future webinars as well. So as you can see on this slide, we will be having our next webinar in 2 weeks. We used to call them weekly webinars, but it got a bit much to run one of these every week. So the next one is 2 weeks today, and it's going to focus on another very important issue, which is the quality of data on COVID deaths and cases and excess mortality associated with the pandemic in low and middle income countries, and particularly the degree to which that data accurately reflects how older people are being affected by the pandemic. And last night we posted this paper, again, a joint paper written by members of the global platform like the one that I presented today, which I think identifies some major shortcomings with the reporting of data and reasons why we should be worried and dare I even say it, angry about the ageism which is very, very evident in this approach to reporting on the pandemic. So hopefully you'll find that an interesting paper if you haven't already seen it, and hopefully it'll be an interesting webinar. And again, if you have any sources of data that you think we've missed, please send them to us. We'll add it to our paper, and as with the emergency strategy paper, we will produce extended and updated versions as we go along. Next slide, please. Thank you so much, primarily to Lucas and Harsh, who do most of the unrecognised work in the global platform, and to many other volunteers and people who are supporting it in different ways. And also, I must acknowledge University of East Anglia, which is providing the small amount but very important funding to keep this activity going. So that's it. And lastly, thank you so much to Leon, with whom I'm sure I'll be talking in the next day or two about all kinds of things that we're hoping to take forward as we deal with this crazy and fast-changing situation. And thank you to all the participants. I think we've had a good turnout this week, and it's good to see some familiar faces on the participant list. I hope you all have a good weekend, and stay safe and stay sane, and stay tuned in 2 weeks.
Bye-bye.
Goodbye.